or non-Hispanic Black or African American, compared with those that are non-Hispanic White. These disparities are likely multifactorial, potentially influenced by differential exposure rates, prevalence of underlying medical conditions, access to care, and other socioeconomic factors. To help further tease apart these issues and identify risk factors for severe COVID-19, CDC and public health partners analyzed the relative rates of in-hospital mortality from COVID-19 using models that adjust for age, sex, race and ethnicity, smoking, and several underlying medical conditions. As shown in the red box, older age was the strongest independent risk factor for in-hospital death, and the risk increased with increasing age. Other characteristics significantly associated with in-hospital mortality include male sex, immunosuppression, renal disease, chronic lung disease, cardiovascular disease, neurologic disorder, and diabetes. Combining data from COVID-19 with population-based data from the Behavioral Risk Factor Surveillance System, or BRFSS, we likewise developed models to assess risk for COVID-19 hospitalization among adults with specific underlying conditions. Again, after adjusting for age, sex, and race and ethnicity, the risk for COVID-19 associated hospitalization was greatest for adults with severe obesity, chronic kidney disease, and diabetes, as shown in the red box. Compared with adults without these conditions, those that have them were 3 to 5 times more likely to be hospitalized for COVID-19. Furthermore, the risk of COVID-19 hospitalization increased with the number of underlying medical conditions, as shown in the red box on this table. While specific risks vary depending on the specific underlying medical condition, adults with 3 or more conditions had 5 times the risk of COVID-19 hospitalization compared to adults with no conditions. Due to increased age, underlying medical conditions, and their congregant living situation, residents of long-term care facilities have been disproportionately impacted by COVID-19. As shown here, residents of these facilities comprise nearly 50% of COVID-19 hospitalizations among adults aged 75 to 84 years, and nearly 2/3 of COVID-19 hospitalizations among adults aged 85 years and older. As such, the Advisory Committee for Immunization Practices, or ACIP, recently recommended long-term care facility residents as a priority group to receive initial doses of COVID-19 vaccines once approved. Similarly, healthcare personnel have been prioritized for vaccination to preserve capacity to care for patients with COVID-19 and other illnesses. Again, based on COVID-19 data, 6% of adults hospitalized with COVID-19 were healthcare personnel, with nursing-related occupations being most frequent. Healthcare personnel hospitalized with COVID-19 had similar prevalence of underlying medical conditions, most notably obesity, as that observed among adults hospitalized with COVID-19, all adults. Likewise, a similar proportion of severe clinical outcomes, including ICU admission, mechanical ventilation, and death, occurred among healthcare personnel as that across all adult COVID-19 hospitalizations. As we prepare for COVID-19 vaccines, it's important to establish baselines to assess their future impact and maintain ongoing assessment of the total burden of SARS-CoV-2 infections in the U.S. To that end, CDC has implemented a nationwide seroprevalence survey to help track the number of people with evidence of previous SARS-CoV-2 infection, including milder infections that do not result in care seeking or testing for acute infection. These involve biweekly testing of approximately 50,000 residual specimens from commercial laboratories for antibodies against SARS-CoV-2. Through the first few rounds of this survey, estimated seroprevalence has ranged from 0.4 to 23% across U.S. jurisdictions. However, as of late September, less than 10% of specimens from most jurisdictions had evidence of previous SARS-CoV-2 infection. In general, the highest seroprevalence was observed among children and adults aged less than 50 years, and lowest among older adults aged 65 and older. Using a different multiplier modeling approach, which uses reported cases and other data sources to then account for underdetection and underreporting, CDC recently released estimates of the total number of hospitalizations, illnesses, and infections with SARS-CoV-2 in the U.S. This analysis estimated that 1 of every 2.5 hospitalized cases and 1 of every 7.1 non-hospitalized cases may have been nationally reported. Applying these multipliers to reported cases through the end of September yielded a national estimate of 2.4 million hospitalizations, 44.8 million illnesses, and 52.9 million total infections. As the figure to the right shows, most estimated hospitalizations occurred among older adults, while most illnesses and infections were among younger adults. So in summary, now, as of December 9th, over 15 million cases and over 285,000 deaths associated with COVID-19 have been reported in the United States. However, based on seroprevalence surveys and models, the total estimated number of infections is likely 2 to 7 times greater than reported cases, though less than 10% of the population in most states had evidence of previous infection through September. Factors associated with increased risk for severe COVID-19 include older age, racial and ethnic minority group membership, and several specific underlying medical conditions. Ongoing surveillance and epidemiologic studies will help inform further development and implementation of candidate vaccines, including assessment of their impacts, safety, and effectiveness. Lastly, even with the promising advent of COVID-19 vaccines, there's continued need for non-pharmaceutical interventions, including mask use, physical distancing, hand hygiene, and environmental disinfection to help bring an end to this devastating pandemic. Finally, I would like to acknowledge the thousands of public health professionals that have worked tirelessly over the last 11 months on the CDC COVID-19 response, including the dedicated staff from the Respiratory Viruses Branch. Thank you.
Of COVID, I think I wasn't on at first. Thank you so much for being clear about the differential impact of COVID-19 in the U.S. population. We have time for relatively few questions. I see Dr. Meisner, do you have your hand raised?
Yes, sir. Thank you very much for that presentation, Dr. Holmes. I would like to ask you about the severity of disease, particularly in older adolescents, that is, individuals who are 16 and 17 years of age, because they have been included in the company's request for an EUA. I assume it's unlikely that hospitalizations and disease are broken down by age, but is it safe to assume that adolescents who are 16 and 17 years of age are similar in the 5 through 17-year-old age group?
Yeah, thank you for that question. So, of course, as we refine to smaller and smaller age brackets, the numbers get smaller, particularly in children, where overall we see lower rates, particularly of severe disease, of hospitalization. In general, we do see higher rates of hospitalization among children aged 0 to 5 relative to those aged 5 to 17. Of course, this is potentially confounded by differential rates of care seeking. As you might imagine, there are certainly lower thresholds for care seeking for the very youngest and most vulnerable children. However, as we start to look at the more mild end of the illness spectrum and look at rates of detection of SARS-CoV-2 virus using molecular assays, we do see indication of higher rates of infection among older children, among adolescents, particularly then as we move into kind of older teenagers and people in their young 20s. Much of this may have been driven in part by outbreaks in the fall among institutes of higher education, but the broader impacts in children perhaps are not entirely clear until the full resumption of normal activities ensues in the United States, including in-person education across all schools in the United States. So we'll continue to monitor it closely, but thus far the indication is the highest rates of illness, severe illness in young children, but higher rates of infection in older children.
Thank you.
Dr. Rubin.
Thanks, Dr. Hall. I was interested in the multiplier that you described. That applies to the diagnosis of infection. Do you think that applies to deaths as well?
Yeah, so we have used at CDC the same multiplier model previously for tracking influenza and generating in-season estimates of the disease burden. And that same approach has been used previously to estimate deaths in the same manner that I presented today for hospitalizations and milder illness. There are, of course, differential multipliers that would have to be considered for deaths, as the rates of underreporting of death are different than those for milder infection. In general, we have better capture of deaths. We have lower rates of underreporting and under-ascertainment for deaths. But as folks are aware, the dynamics of the pandemic itself have greatly changed those multipliers. And so there's also a considerable time component that needs to be factored in when using these multiplier models. So the underreporting of deaths, for example, has changed over time, and the attribution of deaths to COVID-19 has changed over time, which complicates interpretation. But we do have several efforts underway using these models and other approaches to generate estimates of death. And we do feel, as with hospitalizations and illnesses, that the reported number of deaths is likely an underestimate of the true number of deaths.
Thank you.
Thank you. Dr. Gans, we're going to go over a little bit, but please keep your questions short.
Thank you very much. Thank you for that, and I agree, heroic effort to all of the people who are working on this. I had two quick questions. The data concerning the immunocompromised or immunosuppressed individuals is not really granular enough to make it something that we can use in terms of how we're thinking about high-risk populations. There are registries looking at this, but it would be nice if there were some national information that you could provide to us, as well as I didn't see any information from pregnant women, which is a population which we're all concerned about, and we've definitely seen postnatal transmission to very young infants who end up being hospitalized. If you would just take those up.
Yeah, thank you for those comments. Absolutely. There are numerous surveillance efforts currently underway to assess the impacts of COVID-19 in pregnant women. In the interest of time, unfortunately today I didn't have a chance to present those, but through COVIDNet, as described today, as well as another surveillance system called SETNet, which was established during the Zika epidemic, we have been very closely monitoring the impacts of COVID-19 in both pregnant women and subsequently following up with their infants. Thankfully, the rates overall have been relatively low thus far, but as we continue to accumulate a critical mass of data in this demographic, we indeed do hope to have more specific estimates of the risks that are posed to pregnant women and their infants. The early indication is that there may be a higher risk of preterm delivery among pregnant women infected with COVID-19 relative to women without COVID-19. But there's ongoing efforts to assess those and other potential pregnancy-related risks and fetal outcomes.
Thank you very much, Dr. Hall. And it's now time for our morning break. We've eaten into the time a little bit, but I do want to start again at 10:30 Eastern so we can hear from Dr. Messonnier from CDC. See you later.